Hey everyone, it's Alisa with another step 2 question for you. Go ahead and pause the video here, answer the question on your own, and come back and we'll do it together. I'll get started. A previously healthy 1-year-old boy is brought to the emergency department for the evaluation of abdominal pain and vomiting. His parents state that over the past 10 hours, he has been having intermittent episodes of inconsolable crying, during which he draws up his legs and writhes. These episodes have been accompanied by non-bloody, nonbilious vomiting and reddish mucoid bowel movements. On physical exam, temperature is 37.9, blood pressure is 100/60, and pulse is 120, while respirations are 23. He cries when his abdomen is palpated. The remainder of the exam is normal, labs are within normal limits. An abdominal x-ray shows no free air and moderate gas in the small bowel. An abdominal ultrasound is pending, and which of the following is the most likely next step in management? Now, this is a classic patient that you'll see on your wards and on your boards. So let's analyze the patient. It's an infant, 1 year old. He presents with abdominal pain, vomiting, diarrhea. That is a lot of possibilities. He also has non-bloody, nonbilious emesis, which gives us a little bit less to work with. And then finally, the big buzzword here is he has red mucoid stool, which is current jelly stool, which means we've narrowed it down quite a bit. So this is a question for you, but what is that pending ultrasound most likely going to show? Think about that, and I'll mention it a little bit later on. So let's read our options. Pyloromyotomy, air enema, technetium 99M pertectinate scan, that is a mouthful, a LADS procedure, a CT scan, or a lab that this is the case. You also don't really see diarrhea and hypertrophic pyloric stenosis because the problem is nothing's really getting past that hypertrophied pylorus. Air enema. Air enema is a treatment of choice for intussusception, which presents with on and off abdominal pain, and it causes mucoid bloody stools due to partial ischemia of the bowel. So essentially, when the bowel is peristalsing, and it very often is, those migrating motor complexes are the cause of that. But when it peristalses and there's a lead point, bowel is pushed over and it basically creates like this sausage shape and cuts off the blood supply to certain parts of the bowel, and that's where the pain and the blood comes from. So an air enema, which is a treatment for intussusception, which is quite consistent with what this patient has, is not a bad option. The technetium 99 pertectinate scan is used to diagnose Meckel's diverticulum, which can cause ulceration, hemorrhage, and intussusception and obstruction, which could also be consistent with the symptoms here. Noted, the majority of the patients that have Meckel's diverticulum are asymptomatic. However, symptoms can be present, and hematochezia is a common symptom. So you might see red stool. However, let's remind ourselves of the rule of twos. Most commonly, Meckel's presents in children that are 2 years old, and then the other twos are males twice as often as females. 2% of the population, 2% are symptomatic. It's located 2 feet proximal to the ileocecal valve. It's less than 2 inches long and can also have 2 types of mucosal lining. So again, the intussusception that's found here could either be Meckel's diverticulum or lymphoid tissue, but that doesn't matter. What matters is, what do we do to solve this intussusception? And the answer is air enema. So this is actually a really cool picture of what Meckel's, the scan looks like when you're looking for Meckel's. So you see that the stomach lights up on this, and the gastric tissue is lighting up. But the Meckel's, the 2 types of tissue you can have, one of those is gastric tissue. So that's why it lights up darker, as well as the gastric tissue in the stomach. The next option is a lab procedure, which is the treatment for intestinal malrotation with volvulus, which presents in the first year of life with bilious emesis. However, nonbilious is also possible. Constant abdominal pain, constant distension, and then symptoms of bowel ischemia might come on later on. So you'll see bleeding, peritoneal signs, and eventually shock and sepsis from rupture. The abdominal x-ray will show something like the double bubble sign or possibly free air, which our patient does not have. And an abdominal ultrasound might show a whirlpool sign, but you really don't see that done very often, and you won't really see it on your boards. And then another option is appendectomy, which is the treatment of choice for appendicitis, which is very uncommon in the first year of life. Presentation classically is fever, vomiting, irritability, diarrhea, and tenderness and guarding. And then ultrasound, you might be able to see a dilated appendix with some edematous walls, which we don't see in this patient. Next option is a CT scan. CT scans are pretty much never the answer in a pediatric patient. Ultrasound is always the first line. So this patient is not going to need a CT scan. And they already had an x-ray that did not show free air. And then our last option is laparotomy. This patient does not have an indication for laparotomy. Vital signs are normal. Labs are normal. There's no free air. The abdomen's very mildly tender, only to the touch, and there's no peritoneal signs. So we don't need a laparotomy. Which brings us to our answer, which is air enema, treatment for intussusception. It's very safe. It's very effective. But you have to monitor the patient for 24 hours to make sure there's no recurrence of the intussusception. I hope you enjoyed this question. I hope it made sense, and stay tuned for next week.